Hello, people. Welcome, welcome. I hope you're having a wonderful evening. I am going to do a little demo of a patient assessment on John, and then I'm just going to talk through how I start a shift. You know, what kind of education do I provide the patient and their family kind of right at the beginning? How do you phrase it? That kind of stuff. So Chad is not here today, so I don't have someone kind of holding the camera and reading questions. So when I do the demo, I'm going to put the phone up and then do the demo, and then I'll come back and I'll answer questions. So yeah, that's what I'm doing. I'm just gonna jump right in. So if you have questions, put them there. I'll look at them in a minute. I've got Heather just joined, woohoo, and she can help answer some questions that maybe I don't see. But first, I'll go through. Let's just do a example. You know, it says my connection's not good. I wonder if I move. I wonder if I get closer. Maybe over here. So, yeah, that's what we're going to do. So let me see. I've got John here. He's going to be my patient. We're going to pretend that he's had a stroke and that he got TPA. Okay? So I'm going to do, I'm not going to do a full NIS scale. I'm going to do an abbreviated NIS. Because that could be its own video, but we're just going to go through how I would assess my stroke patient at the beginning of a shift, okay? And we're gonna just say he doesn't have this horrible stroke. You know, maybe he's got, we'll just say, some right-sided weakness. So he probably has a left ischemic stroke. So let me just go through what I would have gotten in report. Let's say this is John Kleber, and then this assessment is going to occur after I would have gotten report. So this is John Kleber. Oh wait, here. Look at my patient. Say hi.
Hi.
Okay, I'm gonna. So this is John Kleber. He is, we'll say, a 56-year-old male that presented, was at work and all of a sudden had sudden right-sided weakness, and they brought him into the emergency department. Only past medical history is some hypertension, some hyperlipidemia. Yeah, that's it. Let's just say that's the history. And he was at work and had this weakness. He came to the emergency department and they did a CT scan and found the CT was negative. His blood pressure was a little high, but they gave him 1 dose of labetalol and it came down immediately. So he got TPA. And maybe that was yesterday or something. And we're still doing kind of our frequent abbreviated NIS, you know, stuff. He's been NPO, he's been on bed rest, so our 24-hour TPA isn't up yet, but he's hanging out with me in the neuro ICU. He is alert and oriented, no visual deficits, no language deficits. His only deficit is right-sided weakness, we'll say that. For those of you that don't know, John hurt his Achilles a little while ago, so he already has a little right leg weakness. Sorry, John. So John, when I do my little assessment of you, just pretend like the right side of your body is weak. And let's say, you know, he's been NPO, had a stable night. We were watching his blood pressure pretty closely. Let's say we had to put him on a nicardipine drip, and he's on 5 milligrams an hour of nicardipine through a number 18 in his left, you know, arm. But they turned it off and kind of turned it back on overnight. So they're hopefully, maybe when we start his home meds today, that maybe we can just get rid of that. So we're waiting on everybody to come see him. Speech therapy, occupational therapy, what else? Speech, occupational, and then got a couple scans and some follow-up stuff today. Okay, so let's just say that's the scenario you would have gotten in report. So let me just find a way to kind of set up this phone, so hang with me just for a second here. I want to see if I can get it. That looks pretty good. I wonder if I can get my chair over there. Hold on, guys. Because normally what I do, I don't know if I can get it through. Maybe not. Oh, come on. Come on, chair. I got it. So I'll sit right there. Let me just see if I can see it. Okay. So. Hi.
Hi.
My name is Katie. I'm going to be your nurse today. How are you feeling?
My right side's not so good.
Not so good, okay. I'm sorry, don't laugh. I'm laughing at John, I'm not laughing at the patient.
I need another nurse.
But his new nickname is going to be Patient John, because he truly is a very patient person, and he's always my patient in these videos. Alright, so my name is Katie, I'm going to be your nurse today. How was your night last night?
Okay, I'm better.
Okay. So I'm going to look you over real quick, and then we're just going to kind of talk about what's going to go on for the day, okay?
Okay.
Okay. Can you tell me your name and what month it is?
John Kleber, and it is October.
And then go ahead and answer everything right.
Mm-hmm.
Okay. Are you having any pain?
Yes.
Where is your pain?
Kind of on the right side of my body.
Okay. Okay. Do you have any numbness or tingling?
Yeah, my toes.
On which foot?
My right foot.
On your right foot. So numbness and tingling on the right foot, and just like generalized pain on the right side of your body.
Mm-hmm.
On a scale of 0 to 10, 0 being no pain, 10 being the worst pain in the world, couldn't possibly get worse. You're unconscious. You can't even talk bad. Where would your pain be?
2.
2. Okay. Okay. All right. So I'm gonna have you do a couple things for me. Okay.
Mm-hmm.
I'm gonna lean over him. I don't know if you guys will be able to. We'll see if you guys can see. Okay. What I'm gonna have you do. Can you look at my finger? Okay. Should follow it all the way to the right. Follow it all the way to the left. And back. We'll go up and down. Good. I'm watching to make sure it's going. He can smoothly look at my finger. I'm going to use my pen light and check his pupils. Can you look at my nose? I'm going to shine a bright light. Look at it twice. I look at the one eye. I make sure it constricts equally, or it constricts smoothly and stays constricted. And then I shine it twice. The second time, I'm looking at the other pupil to make sure it's accommodating as well. All right, look at my nose. Okay, great. Okay, what I want you to do, can you look at, I'm going to cover up one of your eyes, and I want you to look at my nose. Okay, stay looking at my nose. How many fingers am I holding up?
2. 1. 3. 5.
Great, let's do that with the other eye, okay? So look straight at my nose. And then if they don't look at my nose, I say, quit cheating. Quit cheating, you have to stay looking at my nose. Okay, look at my nose. How many fingers? He quit cheating.
My bad, that was not intentional.
See? Exactly. You gotta tell him to quit cheating. Okay. Look at my nose. How many fingers?
5. 2. 1. 3.
Okay, good. Okay. Can you smile real big? Good. Okay, go ahead and relax. Looking at facial symmetry. Can you shut your eyes really, really tight like you're keeping water out? Like real tight. Good, good. Okay, go ahead and relax. Can you lift up your eyebrows real high? Good. I think he's hitting on me. It's okay though. Oh, it's not okay. It's not okay. Don't hit on me. All right. Can you squeeze my hands? Okay. So, when you squeeze hands, it's like, okay, I'm noting he's got right-sided weakness. Okay, can you push me? Push me away from you. Good. Pull me towards you. Great. All right. Do me a favor. Can you hold both arms up like this? Like you're holding up a pizza box. Oh, yeah, that's good. I'm going to close your eyes, and I'm going to have you hold there for 10 seconds. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Good. Go ahead and relax. I'm checking to see if he has a drift. I want to see if he drifts his arms down at all. And I want to see also if he has a pronator drift as well. I've actually also had patients, I tell them to hold their arms there. And one that has a lesion on their brain, drifts back up. So that's called a drift check. It's part of the NIS. So that's what you're doing with that. And then, so what let me see. I don't know if I have anything sharp. I think I have anything sharp here. You doing okay? Mm-hmm. You're already tired of your nurse? All right. So what I want you to do is close your eyes. Oh, and what I normally do, I have a little pin here, and I don't normally have one with me. What I would do, because I'm checking to see if you can differentiate between something is sharp and something is dull. But, I normally will take one of the Q-tips, the cotton tip applicators, break one, break it in half, and then you have like a sharp edge, and then I'll use that. Because it's sterile, it's clean, it's cheap, I can just toss it, it's no big deal. Alright, so, hey, sir, please get off your cell phone.
Sorry, Mark. Can't move my right arm. Okay, close your eyes.
Can you tell me if that is sharp or dull?
Still.
Well,
That's a little sharp.
that's a little sharp.
Eh.
And then, so you do face. Sharp or dull?
Sharp.
Okay. And then if his cast thing wasn't here, I do it on his lower leg. I guess I can do it up here.
Sharp. Oh, eyes closed. My bad.
You cheater!
Dull. Sharp.
Okay. Here we go. Yeah, so, and, you know, joke with them, be cordial with them. You know, it's just, in nursing school, I think, you know, you feel so like it's a patient, I don't know how to talk to him. It's just a person. It is just a person. In this case, it's a very handsome person. Okay, and then you might not be able to see. I wonder if, let me see. See his feet. Okay. All right. Can you wiggle your toes for me? All right, good. Okay, he is wiggling his toes here. Can you push down like you're pushing on the gas? Good. I don't want you to do it this way. Can you pull your leg up, flex it up like you're good, good. Can you pick this leg up off the bed for 5 seconds? 1, 2, 3, 4, 5. Good. Same thing with this leg. Is that okay? 1, 2, 3, 4, 5. Good, 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 good. Can you feel me touching here? Is okay there? I would feel pedal pulses down here. And sometimes it takes a second. And if I don't feel them, I can always get a Doppler out. Obviously, I can't feel his over here. All right, so that's kind of the neuro. I'm going to do my... Okay. All right, and then can I have you sit up, sir? Oh, wait, oh, let me put it back. Yeah, sit up like normal. And I'm going to listen to your lung sounds. Normally when you listen to lung heart sounds, don't listen over the clothes, but I'm going to do that here because I'm not trying to make my husband take his shirt off on Facebook Live. All right. Can you sit forward for me? I'm going to listen to his lungs in 6 spots. Give me a good deep breath. Good. Last one. Wonderful. Go ahead and relax. Good. Listen to your heart sounds. Oh, his heart's racing. Wonder if it's because he's got a pretty lady in front of him. I don't know. You're so done. All right, I'll listen to his vowels. Start in the right lower quadrant. I'm going to feel your pulses. Check, refill. Great, great. Also, I forgot something with my neuro assessment. Can you close your eyes? I'm going to touch you on one side of your body, either right, left, or both, and I want you to tell me which side I'm touching you on, okay?
Both. One on the left. Right. Both. Left.
You okay?
Mm-hmm. Left. Right. Left.
Alright. Just want to make sure he can feel both sides of his body. You can tell when he's being touched there. Okay, so I'm going to be with you for the next 12 hours, okay? Today we've got a lot going on, alright? So the physical therapist and speech therapist are both going to come see you. with this stroke, you know, it impairs your ability to walk and talk and do various things. So it's really important that we have the speech therapist, the physical therapist, and the occupational therapist come see you and evaluate, you know, how bad the weakness is, kind of give us a starting point to see how we can structure our therapy, okay? And frequently, you know, you haven't had anything to eat or drink. Frequently with strokes, your ability to swallow safely is impaired. And it's happened so frequently with strokes that every time we have a patient come in with a stroke, we have a speech therapist evaluate them. So this morning at some point, there will be a speech therapist that'll come by. They'll do an evaluation of you and then see if it's safe for you to swallow. If they say it's safe for you to swallow, then the doctor said that we can give you food or drink, okay? So, but until they come by, I can't give you anything to eat or drink. So sorry. We can swab your mouth out and make it moist with swabs, but it's just, at this point, it's not safe to eat or drink, okay? Let's see, I talked to MRI. We're going to get an MRI of your brain. They're going to give me a call. They're doing some emergent ones right now, but probably sometime this morning we'll go down there. So the purpose of an MRI is that CT scan that you got yesterday to check to see if there was a bleed in your brain. There was not a bleed in your brain, which is good, and that's why you got that medication called TPA. But what happens is when you have an ischemic stroke, which is what we anticipate that has happened, those take a little while to show up on a scan, okay? Did I turn that back? I don't know if anyone could see. Okay. So that takes a little while to show up on a scan. So that's why the next day we typically do an MRI. It's a much more detailed image. We can see a lot more, and it shows us more. And it also gives time for that stroke to show up and see exactly what we're working with, okay? So we're going to do an MRI today. It's very important. Are you claustrophobic at all? Do you get nervous in small spaces?
Not really.
Have you ever had an MRI before?
Yeah.
Have you ever had one of your brain before?
I don't think so.
Okay. All right. So, let me know if you get nervous or if you're nervous about small spaces or anything. There's medication we can give you, but we'd like to not give it to you if we don't have to.
Okay.
Okay? So I'll get some blood work a little bit later. We do a follow-up complete blood count, you know, a full day after that you had that medication. If everything looks good and the doctors come by and they say, hey, I'm, you know, happy with the progress that we've made, we'll go ahead and get you out of the ICU. Okay?
Okay.
What else can I tell you? There will be a neurologist that comes to see you today. There will also be a critical care doctor that comes to see you today. I don't know what time they're going to be by, but I'll try to be in the room whenever they come by. Make sure we get all your questions answered. So my name is Katie again. I'll be with you all day. And then Tasha is our CNA, and she's going to be taking care of you as well. She's the nursing assistant. Okay. Your call light is here. Don't get up without me. It's really important that you're not getting out of bed right now because that medication you got yesterday, it thins your blood a lot. And that means that if you were to fall, you know, you have this new weakness on that side. If you were to fall, you know, you could bleed more than you would normally, and that's you know, why we're concerned about people getting up out of bed so soon after that medication. So it's really important you hit that call light and let me know when you need to get up out of bed, and I can help. Actually, wait, back up. You're not going to get out of bed. We're going to do a bedpan until the 24-hour time. So please let me know if you need to use the restroom and hit that call light, and I'll come help. Or Tasha will, whoever's available. I think I hit all my bases. Do you have any questions for me?
How long will I have to use a bedpan?
Until the 24-hour TPA time is up. Let's just say it's 12 o'clock. Noon. So you can use a urinal in the bed if you have to pee, but if you have to have a bowel movement before noon, we'll have to use bedpan. Okay. But hopefully we won't have to do that.
Okay.
All right. And then keep in mind, guys, I would be looking at his skin fully, but I'm not going to do that right here. What else? Okay. So what I'm going to do is I'm going to go check out my other patient, and then I will be back with a couple medications. Okay?
Yep.
All right. All right, guys.
Mac, come
here. Let's see.
Mac, come here, buddy.
All right. Sorry, guys. I couldn't see you guys, so I don't know if that was a bad angle. Tosh are here. We've got the therapy dogs in here. So this is that's kind of my spiel, I guess. Let me put this up here. I hope you guys can see that. Okay, that's kind of what I do when I have a patient that has TPA. That's kind of how I assess them, kind of what I start out with, and kind of how I talk to them. You know, let them know what's going on for the day, so they have something to anticipate at this. And I would also be talking to whoever his loved one is, you know, to make sure they know what the deal is. A lot of times if they're in a neuro ICU, they are really nervous. They had a stroke yesterday. They got this scary medication. They're having these big exams and getting a crash course in neurology. So the more information that you can provide, the more predictability. Is your patient single? Oh, Lisa. He is taken, guys. I know he's handsome. Patient John. So that's kind of what I do. And I want to make sure I answer questions. Cute patient. I love it. Okay. Let's see. Is this a neuro? So that was my normal assessment. Oh, wait. All right. Let me scoot. I'm going to move back closer to my router. All right. So that was like my basic assessment with an abbreviated NIS. So when you are taking care of a stroke patient, you have to do a stroke patient that received TPA. You have to do these abbreviated NISs at very specific intervals, and you have to do a full National Institute of Health stroke scale at various intervals as well. But I don't want to do a whole one because that's a lot of, you know, stuff to do right now. And kind of a whole nother video, I guess. So I just did my abbreviated NIS, so doing a drift check. You know, drift check, I don't know. If they have a drift, I'll let the physician know, but I honestly can't tell you exactly what having a drift would mean. What's really important is for me to know baseline. Did you have a drift at all at the beginning? And then if we're seeing one develop and you did not have one at the beginning, that signifies something is changing in their brain. So I need to let the physician know, hey, we haven't had a drift and now we're having a drift. So I can't say specifically what that is indicative of in their brain. I think it depends on where the lesion is or where the injury is. But if there was one and was not one and now there is, that's a problem and a change. So that's, you know, what I'm looking for. Wasting too much time. If this were a real stroke exam, epic failure. So my response to that is, this patient we already knew had a stroke. This patient, this isn't the initial stroke exam, you know, maybe in the ED. This is not a stroke exam from someone on the floor that all of a sudden had a stroke. This is a patient, if you were listening, that we already knew had a stroke. We have administered TPA, and we are also doing our consistent follow-up neuro checks. So I am a neuro ICU nurse. I got report that this patient already had a stroke, and I knew that I needed to do an abbreviated NIS. So this was not an exam to see whether or not the patient had a stroke. This patient did have a stroke, and we knew that. So I'm sorry, Sarah, this was not an epic failure. All right, next. Thank you, Terry. This is a bad angle. I could see a lot. Sorry, guys. I'm talking way too much. Oh, sorry. You know what? Sorry, not sorry. That's if you're a patient that has had a sudden, you know, stroke, I'm going to go ahead and educate you as much as I can and hopefully make you feel as at ease as possible after you've had a pretty life-altering event. So that was not too much, and if it was too much, and sorry, not sorry. Okay, cute patient. Let's see, patient. NPO, nothing by mouth. So NPO means they can't have anything by mouth. I don't know what the PO, it's something Latin. I don't know exactly what those words stand for, but it basically means they cannot have anything to eat or drink. Typically what they do is can't have anything to eat or drink for 24 hours after TPA has been administered. It's kind of a typical order for a TPA patient. Do you always do this specific assessment for each shift? So this is me doing my neuro ICU assessment on a patient that I know had a stroke. So if I had a patient that had pancreatitis, you know, I'm not necessarily going to be checking their sensation on both sides. Like I wouldn't be doing it that specific, but I knew this patient had a stroke, and I'm doing the abbreviated NIS. So that is a specific neuro thing. So I would not do that specific for everybody. Thank you, Mary. Oh, per orbitus. Oh, that's interesting. I did not know that. So okay, I think I got through all the questions and comments and everything. So if anyone had any more, please feel free to comment. How many patients do I get in the ICU? So hopefully what you get is 2 patients to 1 nurse. That can be pretty manageable depending upon what's going on with the patients. If they're really, 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 really sick, you may get just 1 patient. And then if staffing's really, really tough, you might get 3, and that's a lot, and that's really tough to get in. If you have a fresh stroke patient that just got TPA, they're typically a 1-to-1 patient because the neuro assessments are so frequent. The reason is because when patients get TPA, they have a risk of hemorrhagic conversion, and we have to watch very closely for that. So that's kind of why neuro patients that have a fresh TPA patient, they're typically a 1-to-1. Really important that we're watching really close for it. Like I think that actually was Michael. He was asking about what the drift signifies. So I'm watching really closely, because if I had a patient that had an ischemic stroke, they got TPA, they did not have a drift, and then we're a couple hours after TPA and all of a sudden we have a drift, I'm concerned that we're having some bleeding from the TPA. So we're gonna probably go get a CT scan. I'm gonna call the neurologist, let him know, hey, we've got a change going on, because we're so worried about that. So that's kind of what's going on with that. Interesting, did not know that. So I've got Mac here, sorry, it's trying to get around me, jeez. Okay, did anyone have any questions? It's kind of, I think the really important things to do when you have a new patient, I talked specifically about stroke, is you want to do your assessment. And while you're doing your assessment, you want to build rapport with them. You want to talk to them. If you noticed, I sat down next to him, and instead of like standing over looking at him, I sat down next to him. I'm going through kind of my checklist in my mind, but talking to him, kind of, like he's a person. I think one of those things in nursing school, it's really hard and really challenging, because you hear and you're taught so much about patients have this and this and this, but if you really just look, he's a guy that had a stroke, and if I had a stroke, I would really want someone talking to me and really explaining everything that's going to go on every step of the way. Keep in mind, this is an ICU patient, this is not a floor patient, so there's more explanation that's typically needed. So that's kind of the deal. That's kind of how I would go about assessing a patient. Thanks, Lisa. So let's see, what else can I tell you about rapport with patients? I also like to ask them what they would like to be called at the beginning of the shift. Introduce myself. Just don't say, I'm your nurse standing over you, like I'm not gonna, I typically like to kind of break the touch barrier. I like to do a handshake. Not everybody likes to do that. Maybe a hand on the shoulder, just a little, hi, I'm Katie, I'm gonna be taking care of you, something like that, just to let them know, like, hey, I'm here for you today. If you have anything going on, please let me know. You always want to make sure that they have their call light nearby. They know if they can or cannot get out of bed by themselves. Even if they're in the ICU, sometimes people are like, yeah, they just think they're going to get up. And it's like, oh my God, no, how do you not know you're not allowed to get up? You want to let them know. What else did I talk about? Yeah, so that was kind of the basics. Oh, thank you so much, Rosalind. Oh, I love that name. Let's see, what else? Yeah. Okay, that's it. That was like my shortest one. Did anyone else have any questions? I'm more than happy to hang out and do some questions if people had them. But don't want to like keep you guys if you don't have any questions about, basic assessment, building rapport with patients. I think in nursing school they explain the big, huge assessment, which, a lot of times you're doing, not every little aspect of that. You have to really decide what's going on with the patient. So I had a stroke patient, so I'm focusing heavy on neuro. Yeah, I'm looking at everything and making sure I touch all my bases, but I'm not, you know, doing unnecessary things and, you know, taking too long and that kind of stuff. Yeah, so I think, I don't know if you guys have anything else. I'll give you guys a little bit for any questions. It can be related to doing assessments on patients in the real world. You know, oh, maybe I can show you guys my scrub sheets. I use these sometimes. I didn't pull it out, but I got these. Oh, I love so we have, if you go to scrubsheets.com, we've got these kind of laminated cards. I really like these. So I was talking about the NIS. The full NIS scale has things like this where I have to have people repeat words. So I'm checking for dysphagia. Aphasia. I didn't do that. I could tell when I was talking to him that he was speaking fluently, and you know, I could tell that he understood what I was saying and what was being said to him. I was answering questions appropriately, and clearly dysphagia. You know, I'm trying to make sure if he's having problems speaking. So I work in a neuro ICU. And I typically have 2 patients on a normal day. But if I had a patient that was a fresh stroke patient with TPA, that would be a 1-to-1. Yeah, scrubsheets.com. They're wonderful. There's 50 of them in a pack, 48. And then they're all laminated and everything. So those are great resources as you're learning how to do this stuff. That's my normal assessment. I've been doing this for quite a while. And, you know, and a neuro assessment on him is kind of a little different than an unconscious neuro patient. That's a very different assessment. But some of the basics are still the same. Your heart sounds, lung sounds, bowel sounds, peripheral pulses, skin check, that kind of stuff. But if I have a ventilated patient, you know, I've got to do additional things. So yeah, that is what I got, guys. I don't know what else to tell you guys. So I think I'll go ahead and sign off unless anyone has any other questions. Thank you guys so much for tuning in. I hope this was helpful. I want you to know that assessments, you know, you'll get easier at them. You'll get, you know, it'll be a lot easier to do the more often you do it. If you just go seriously from head to toe, it helps. Building trust in a patient that is blind. Oh, that is a great question. I have had blind patients, and I've had deaf patients too, which is really, really, really hard when you're trying to assess stroke or like neuro status. Is really challenging to assess on a patient that cannot hear or is just hearing impaired. But with a patient that's blind, you really want to make sure that you're talking a lot and letting them know what you're doing, where you're at. I think having I've got Mac in here, having your, you know, maybe a hand on their hand, and you know, hey, I'm coming in the room, and you know, I think just, you know, you cannot. Our patient is, oh my gosh, our fall risk has escaped. Elopement. What is that? A code yellow. So, you know, with blind patients, you just want to, you know, I would honestly ask them at the beginning of the shift, hey, what can I just want to make sure that I'm doing everything that I can for you. And I want to make sure that, if it helps for me to stand in a specific spot or do whatever, or maybe I can make sure I get some Braille stuff for you, you know, that kind of stuff. I think if you just ask patients that kind of stuff, I think that's really helpful. Hey, I've got some. Here's Tosh McIntosh. Hey guys, I think I have new patients here. So that can be challenging, but honestly, if you just ask them, I think that would be great. I currently practice in North Carolina, but I have also worked in Illinois. And NRSNG, we do a Facebook Live every week. Yeah, actually, someone just answered. So, yeah, I don't think I'm on next week. It's, yeah, usually Tuesday, Wednesday, or Thursday in the evening, so we can catch you guys maybe when you're just got off work or something like that. And the videos stay on our saved thing. So if you missed it, or if you think someone else would like it, you can go to the video and share it. Excuse me. So yeah, that is how I assess my patients in the morning. That's how I talk to them in the morning. That's how I take care of them. I think it's really important for us to be observant and proactive with our patients, proactive with your patient education, so they understand what's going on for the day. If they understand what's going on, they're more likely to be compliant because they know what's coming. So, okay, I know physical therapy is going to see me today, as opposed to some random person walking in the room and say, hey, I'm from physical therapy, I'm going to assess you. Well, hey, nobody told me that was going to happen. Imagine how frustrated you would be if you had all these random people coming in the room that you've never seen before and nobody warned you that they were going to be coming. So it's really helpful to do that kind of stuff because, it's already a very scary, new, unpredictable environment. It's really important to provide as much predictability and routine as you can. And I know that's not super easy when someone is in that in that environment. But the more you can do as the nurse, the better. You are the leader of the healthcare team. You are the person that is with that patient all day, every day. You have multiple people coming in from the healthcare team, but it is you who are their home base. So it's really important at the beginning of your shift to establish rapport with them, establish trust. And you do that by really being confident, knowing what you're talking about, being reassuring, making it evident that you care about them, asking how they're doing and waiting for an answer, asking if they need anything in a tone that invites an answer. So don't say, hey, can I get you anything, as you're walking out the door with your hand on the door. I mean, I don't know about y'all. If I was a patient, I would say, I'm fine, even if I didn't need anything, because clearly that person has somewhere more important to be than with me. So it's really important to, especially at the beginning of the day, to establish that. And if you do that at the beginning of the day or the night, whatever you work, you'll find that your shift is a lot better because they trust you. They feel like you know what you're doing. And I've had patients that, I've had to work a little harder for their trust, but once I got it, man, they let me do my job because they trusted me and they trusted whoever was taking care of them, and then we could all kind of relax. And then the patient ended up doing better, getting better care, just because, okay, I trust the process, I trust the nurse, they're going to take good care of me. So that's my spiel. Thank you guys so much for tuning in. Feel free to share this if you thought it was helpful. Check out scrubcheats.com with those cool little cheat sheets for clinical. It's going to be a little mechanical, a little rough at first. I like to compare this, learning how to do this, like a, how could we rebuild trust with the patient with the law? Yes. Okay. So that's a great question, Sean. The question is, how could we rebuild trust with the patient when the previous nurse lost that trust? You will have to do that at some point, you will. It kind of sucks, but yeah. So maybe it was the nurse's fault. Maybe it wasn't, but you got to start your day on point. You got to, actually so let me tell you a story. I had a patient that, I can't remember if they were a stroke. I think they had a stroke, and then they were NPO. They couldn't have anything to eat or drink, and they said speech therapy came and saw them. They felt like it wasn't safe for them to eat, but they didn't want to insert a feeding tube. They thought maybe if we give her another day or two, she'll be okay, and we won't have to insert a feeding tube. And y'all know we don't want to put one of those in if we really don't have to. So we gave her another day or two, but the family was really mad because the patient hadn't had anything to eat for 3 or 4 days. The patient was very ill, though. The patient was not hungry. The patient was very, I think food was the last thing on their mind. But they were very upset about it. And that I think the previous nurse had been kind of like, we'll take care of it, and kind of pushing it off and never took care of it. And the family was just like, y'all don't know what you're doing. So I was told this in a report. So I'm like, okay. The patient can't really talk, but to the family, the food is the most important thing. The most important thing. So what can I do to facilitate that process? Even if I can't do anything, I want them to know that I'm trying. So what I did when I heard that in a report, before I even went in there, is I called speech therapy. I was like, hey, when are y'all going to be by? Oh, wait, no. Let me take that back. No, I did not do that. I got a report first. And I knew that was an issue. So I said to the family, speech therapy gets here around 8 or 8:30. As soon as they arrive, I'm going to give them a call because it is not safe for me to give her food right now. It's not safe. And speech therapists, that, they are mastered, prepared in what they're doing. They are very knowledgeable, and I want to, it's not safe. The risk of her getting pneumonia is too high, or him, I can't remember. It's getting too high. Is too high for me to give them liquids. So we got to wait for them to come. So I'm going to assess, or I'm going to call first thing when they get here. I'm going to call them and see where she is on the list, and see if I can get her moved up for us, and see if they can come see her first. And then, we'll see where we go from there. Immediately, it was just like, okay, they know this is a big deal to me. Like, he was just kind of relaxed a little bit. And that gave me from 7 a.m. till 8:30 to get a bunch of stuff taken care of and done. And I called them, and they came. I think they got there at 10-ish. But I let them know, hey, I talked to them. They're going to be here around 10. And every step of the way, I notified the guy. Like, hey, I just want to let you know I called him, waiting to hear back. Okay, I just talked to them. They're hopefully going to be here around 10. They got a little bit of an emergency they're dealing with right now, but they're going to be here as soon as they get done with that, hoping around 10 o'clock. And then I let the speech therapist know about the concerns before, so that she made sure to give a little bit more education typically than usual, because he was pretty upset. And then I made sure to touch base with her afterwards, so I knew what to reiterate. And I wanted to ask him, okay, what did you hear the speech therapist say? And I wanted to hear what he said, so that way I could make sure he heard what she was saying, if that makes sense. So, every step of the way, even though I didn't need to tell him when I was calling. I didn't need to tell him what time they would be there. I didn't technically have to do that. But I could tell it was really important to him. So I just kind of did that, and that he went home that day for like the first time in a while, I remember. Because it's like, okay, they got whatever was really important to them taken care of, if that makes sense. So I think you have to have honest communication, empathy. I think it's really important to make sure you're talking to the patient or family or whomever, and ask them how they're doing or what's going on without trying to think of something to say back. Just kind of listen to what they're saying, and empathize with them. Try and understand what they're feeling and what they're going through. Try to put yourself in their shoes. And I gotta be honest, a lot of people, they just want to be heard. They want to know that I had a really bad night. That nurse was really really scared right now, and that nurse was like really flippant with me, and it made me feel blah blah blah. And sometimes people just need to verbalize how they feel. And if you are just this calm, confident, and reassuring presence, a lot of times that is what they need. So, and that can really build trust. So taking time to educate as often as possible, reiterate, asking questions like, so what did you hear me say? Or when you know that they just spoke with the doctor, asking them, what did the doctor say? As opposed to, did they tell you, did they update you? Okay, good, and assuming they know what's going on. There's no such thing as over-communication in healthcare, is my personal belief. A lot of these patients and family members are all of a sudden learning this last-minute, terrifying medical stuff they never thought they'd have to learn. So it's always important to see if they really understand what's going on. A lot of times they don't. A lot of times they need more reiteration. They need someone to tell them, hey, there are no stupid questions. Tell me what's going on. What are your concerns, and how can I address them? And many times they don't need you to go fix some problem. They really just need you to be someone that's listening, that's not got an agenda, that's got somewhere else they've got to be really quickly, even though you may. Maybe just investing those 5 minutes instead of like, okay, I got to go. But maybe sitting there for 5 minutes and not being in a rush out of the door can really go a long way. And they know that when they need you, you're going to be there, kind of thing. And as opposed to like going meeting the basics and then leaving, if that makes sense. So yeah, I don't think I got any more questions. Thank you guys so much for tuning in. I think had a few negative comments, which kind of like bummed me out a little bit, but I really appreciate all of you guys tuning in and, kind of saying some really positive things. I really appreciate that. I think it's really important to me that you guys feel a little bit more kind of prepared and supported than I feel like I did when I went through nursing school. I would have really liked to see a nurse, do some of this stuff, and that's kind of why I'm taking, time out of my evening to do this, and time out of my husband's evening to do this for you guys, because, man, being a nurse is just kind of scary getting out there. So I hope, whatever support we can provide makes your transition into a successful bedside nurse a little bit easier. And maybe you're more confident in yourself than I was, because it took me a long time to get to a point where I felt like I was real confident. So, oh, you start your first nursing job next week, Bianca. Congratulations. I'm really glad this is helpful, guys. Really, really glad. Oh, wonderful. Oh, yay. I'm so glad that this has been helpful. Like, honestly, we work really hard for you guys to try to be able to support you when you're going through this process, because me, John, Heather, Susan, we've all gone through it. We know it's tough. And we want to provide some of the support that I feel like is really necessary as you're going through this. Maybe, your professors and your instructors have to play that role, but I think it's really helpful to have somebody that's not a professor, that's not a clinical instructor, that's in the profession, just to provide some support to you guys. Y'all get any Sean, okay, I don't know if you have that one or that image, but that y'all got any more of that free NCLEX prep? That I died laughing. That was on Instagram. Okay, Heather or Sean, I need y'all to put that picture up. I don't know if you can put pictures in this, but I want you to do that so that everybody can see. We have a lot of NCLEX prep stuff. I want to let you guys know about a podcast I'm doing right now. It's called the Unofficial NCLEX Podcast. So what happened? Oh, you're Sean, hilarious, like dying laughing when I saw that. Well done, sir. Well done. But John had a great idea, and I just kind of ran with it. He went and got so if you go to the NCLEX website, they have the test plan there for educators to see, and to know how to educate nurses or nursing students about, this is the stuff that you really need to know to be a successful nurse. It's on the website. It's for everyone to see, and I think it's great information. So what we did, there's 508 points. So we turned those into podcast episodes. I think we've got 30 out now. I think. I'm not sure how many are out now. I think 30 are. The first 30 pages of the doc. It's free. Totally free. And it's just me kind of going through those points and talking about my clinical experience with them. And you know what, honestly, I hated studying for the NCLEX. I hated studying for it. I hated taking it. I hated everything NCLEX. And I'm going through this test plan oh, that's important. That's important. That's important. I honestly have not run into a point yet where I'm there's no point for this to be on here. You know what I mean? I really was kind of blown away at how oh yeah, this does matter. So if that's any encouragement to you guys, it's been 6 years since I've taken the NCLEX, but now that I'm looking at what they're told to teach related to it, it's oh yeah, this makes sense. This is important to know, and I have a story about every little single one of them because it's important and I've had an experience with it. So alright guys, thank you so much for joining me. Thank you to John, patient John, Mac and Tosh, my substitute patients. Thanks for tuning in, guys. If you think someone may enjoy this, please share. And also, if you have a need or if you have a video you'd like us to do, I saw last week that people were really enjoying me assessing John. That's why we did it again this week. And I focused it a little bit more on neuro because I was going to do it last week and just didn't have time. So if you guys think of something, some need or something you'd like to see, keep in mind we're doing these from our homes, and it's not like I got a ventilator here or an arterial line or a EVD that I can demonstrate with, but any needs that you guys have, please comment. We'll take a look at it and share, and hope you guys have a wonderful Thursday evening, and have a great night, guys. Bye.